unmute himself. बस हो गया, बंद कर दो इसको अंकल। Professor Rahman, can you unmute yourself? No.
Yes, how are you?
Yeah, fine, thank you. So, now when can we start with this?
Yeah, I think so. You can start.
Yeah.
Just 1 second, please. I have to.
We're actually live.
Okay, no, madam, no problem.
I'm forwarding the Zoom link again to Naruma and Manohar. That's why I'm taking time.
Ma'am, you can present your case first.
Okay, okay, now complete. Now I can present.
Yeah.
Okay.
So, no, wait. Now,
Dr. Parashar, you can.
Can we start? You tell me when.
নারুমা আমি শুরু করে দিই, ওরা সবাই ফজলুর রহমান স্যারও জয়েন করতে পারছে, আপনি জয়েন করেন। আচ্ছা, ওকে, আচ্ছা আচ্ছা।
Actually, we are live, sir. We have to start.
হ্যাঁ,
Yeah.
আপনি কি মনোহরকে
Now,
বলেন?
let us stop talking now. Yeah. We can start on.
The live stream has started. We can start the meeting.
Okay. Good evening, ladies and gentlemen. I am Dr. Parashar on behalf of Indian Academy of Echo, and Professor Fazlur Rahman will be representing the Bangladesh Society of Echo. Now, every month we are having a joint webinar with various international societies and centers of repute, so that it is a mixed case presentations of various types or so. So we had one webinar with Indonesian Society of Echo, we had one with the Philippine Society of Echo, and today we have with the BD Echo, with whom we have got a very, very long association. It will be mainly a case-based program. One of the speakers will be alternating with each other also, and you are requested to finish in 10 minutes time. So I will now request Professor Fazlur Rahman to say a few words and invite their first speaker also. Please unmute, Joja. Please.
Thank you very much, Professor Parashar. Many thanks to give us the opportunity to make a joint program on echocardiography by Indian Academy Echocardiography and Bangladesh Society of Echocardiography. Actually, due to unavoidable circumstances in the last year, we cannot arrange our big program, BGD Echo. Inshallah, in the coming July, we are planning to do so. By this time, this program is very useful to us as well as other international faculty as well as participants on Echo, as organized by our beloved as well as our guardian, Professor Parashar and his team. So I think it will be very informative for all on echocardiography. Thank you very much.
You can invite Professor Tuhin, please.
আমাকে অলরেডি আমি প্রেজেন্টেশন শুরু করব। ওকে,
Tuhin, Professor Tuhin, you are requested to start your lecture.
Please share your screen, your slides.
can you see my slide?
Yeah.
Yeah.
So
Yes.
respected moderators and distinguished delegates and faculty, a very good evening. My first case title is Roadblocks to Flow, Steering Through Heart Obstruction.
Unmute, no?
Madam, we can hear you.
The slide is not moving. Okay.
I think Dr. Gupta will be helping you, or Simmi.
It's not moving. It's stuck.
Can you reshare your screen, ma'am?
Reshare. Okay, stop share and reshare. Okay. Can you see?
Yeah, we can.
Yes.
Try moving your slides, ma'am.
Okay. Okay, so the title I have already mentioned, From Roadblocks to Flow, Steering Through Heart Obstruction with a Smile. The slide is not moving. That's the problem. Slide is not moving. It's stuck.
This appears to be a PDF rather than a. This is not a PowerPoint presentation. This is a PDF.
No. It's a PowerPoint presentation. It's not a PDF. Okay,
Just push a button down, like arrow down arrow. If it's
yes, I'm pushing. While Jairan, I did this and it ran smooth, but now it's not moving.
because it's increasing and decreasing in size. That's what I'm saying. This is increasing and decreasing in size.
Okay, now it's moved. Okay. So a 12-year-old girl presented to our pediatric OPD with the complaints of shortness of breath, cough, and recurrent respiratory tract infection. She was admitted in a local hospital few days back and treated with antibiotics along with bronchodilators. She was evaluated in 2 different centers and was diagnosed as a case of mitral valvular heart disease in one center and as a case of chordatum sinister in another center. Here is her X-ray showing that straightening of the left border of the heart with RV type apex. ECG shows there is incomplete RBBB with right axis deviation and sinus tachycardia. 2D echocardiography, parasternal long-axis view, there was a cystic mass attached to both leaflets, and apical 5-chamber view, there is mobile cystic mass predominantly attached to AML, and there was no alveoli obstruction. The still picture in the center, we see there is a round cystic mass attached to both leaflets. Here, apical 4-chamber view, we can see that the cyst is obstructing the mitral inflow. There is turbulent jet, and on the right, a spectral Doppler across mitral valve show that the severe sclerotic gradient, mean gradient is 11 millimeter mercury, showing that there is severe mitral inflow obstruction by the cystic mass. Here, color flow imaging of the tricuspid valve and a spectral Doppler showing that the peak gradient across tricuspid valve was 98 millimeter mercury, indicating that there was severe pulmonary hypertension. 3D echo showed that there is a cystic mass attached to mitral atrial surface of the mitral valve. The margin was clear and content looks hypoechoic, and the shape changes with different phases of the cardiac cycle. So with this echogenic cystic mass, we change shape in different phases of cardiac cycle, and attached to mitral valve, we diagnose the case as blood cyst of the mitral valve, and we refer the patient for cardiac CT. A CT report a large multiloculated cystic structure having contrast-filled blood content measuring about 5.2 into 4.2 centimeter. Lesion appeared to arising from posterior mitral leaflet and causing severe mitral inflow obstruction. The patient was managed medically with diuretics, beta blocker, and respiratory tract infection was treated and referred to the cardiac surgeon. And surgical management comprised of excision of the cyst on pump with posterior mitral angioplasty and tissue sent for biopsy. Biopsy report showed that cyst wall devoid of lining epithelium, backed fibrocollagenous tissue showing degenerative changes, and mild infiltration of the inflammatory blood cells. No malignant cells were seen. So we did the postoperative 2D echocardiogram, and there was no mitral inflow obstruction. Mitral leaflet movement was normal. Apical 4-chamber view, we can see that the normal mitral valve leaflet movement and there was no obstruction, but a tiny tag of tissue attached to the AML. This was the tiny sac wall which the surgeon attached with AML with a persisting suture to keep the mitral, to save the mitral valve because the child was 12 years old. And 3D echo, we can see that the normal leaflet movement and there was no mitral inflow obstruction. And we are doing regular follow-up of this patient. 6 months has passed and the patient is doing well. There is no recurrence. So here are a few words about the blood cyst of the heart. Blood cysts of the heart are rare in adults. Blood cysts are relatively common in newborn. In majority of cases, they disappear spontaneously before the age of 6 months. The first intracardiac blood cyst on mitral valve was reported in 1844. In 1983, Hosser et al. Presented the first echocardiographic description of a cardiac blood cyst. Blood cysts are predominantly seen on the valves, anteromytal leaflet being the most common affected structure. In a few cases, blood cysts were found to attach to the atria or to the ventricle. Intercardiac blood cysts have been related to different symptoms, including dyspnea, chest pain, syncope, and rarely neurologic deficit due to embolism. Echocardiography is considered the imaging modality of choice for the diagnosis of intracardiac blood cysts. Cardiac blood cysts have typical ultrasound features, including an echolucent core and a thin wall with clean boundaries. There is no consensus on the management of blood cysts. In the absence of symptoms, they are typically managed by observation and echocardiography follow-up to monitor cyst size, presence of obstruction, and valve dysfunction. In conclusion, intracardiac blood cysts are rare, benign cardiac masses. The mitral valve is the most common site of the blood cyst. Echocardiography is the best imaging modality for diagnosis. Difference in size and attachment site account for the variation symptoms. Management should be individualized based on the presence of symptoms and complications associated with the intracardiac cyst. We report a case of blood cyst attached to both mitral valve leaflet in a patient presented with recurrent respiratory infection and shortness of breath. The cyst was detected on transthoracic echocardiogram. Diagnosis was supported by cardiac CT and was treated successfully by surgical excision. Our case underlines the importance of multimodality imaging and multidisciplinary approach for the diagnosis and management of this rare abnormality of the mitral valve. Thank you for your kind attention.
The audience can put their questions in the chat box. I just want to know what were the differential diagnosis you put at that time before the CT?
No. Actually, this diagnosis, we did not put any differential diagnosis because of the cystic nature of the mass, and it was attached to the mitral valve, and the cystic mass changes its shape during phases of cardiac cycle. So in this case, I was diagnosed. I diagnosed the case, and only one diagnosis: blood cyst of mitral valve. I
Great,
didn't
very good.
diagnosis.
So now we'll invite Dr. Hardeep Grepal, who is the senior consultant in clinical and preventive cardiology at Medanta Heart Institute, and she has got a lot of experience in getting fellowships in various UK, US, and other things. So she'll be presenting her case. Please.
Good evening, everyone. Can everybody see my slides? And am I audible? Okay. First of all, I would like to thank Dr. Parashar and the whole organizing team for inviting me and for giving me this opportunity to present here today. So let's start with the case. So, okay. I think the same problem. Okay. So this was a 43-year-old gentleman with no history of hypertension, diabetes, or any other major comorbidity. So this patient presented with history of cough and symptoms of uveitis about 6 months prior to he presented to us. So during his initial evaluation, he was found to have multiple mediastinal lymph nodes, and the patient was started on empirical ATT. Patient took ATT for almost 6 months, but he continued to have cough and also started to have symptoms of effort dyspnea, which was progressive and worsening. So a repeat evaluation was done, and an echocardiogram showed severe LV systolic dysfunction. So patient was concerned about his ongoing health issues and now new cardiac issue. So with this, he presented at our center. So during his, at the time of presentation, his clinical examination was pretty much unremarkable, except that the BMI was high at 31. Initial lab investigations were also normal, except that ESR was high at 47, and patient was found to have high LDL. MON2 test was also done, which was negative. Now, these are the echo images. So these are parasternal views. And as we can see, LV appears to be dilated and there is global LV hypokinesia. But the inferolateral wall, as we can see in this parasternal long axis view, appears to be more hypokinetic in comparison to the rest of the segments. These are the apical views. So pretty much same findings: global hypokinesia, LV dilated, severe LV systolic dysfunction. But in this two-chamber view, we can appreciate that this inferior wall is akinetic and I would say rather scarred. Mitral inflow pattern showed E less than A. E prime is significantly reduced, but overall E by E prime ratio was preserved, reflecting normal LV filling pressures. So this is the bullseye plot obtained from strain imaging. And as expected, the GLS was markedly reduced at minus 7.6%, but the bullseye plot was not giving any specific pattern. So based on these findings, history of uveitis, cough, mediastinal lymphadenopathy, which was not responding to ATT, plus the echo findings, which showed severe LV systolic dysfunction with inferior wall akinesia, a possibility of sarcoidosis was considered. Now, to further confirm our diagnosis, a FDG PET and cardiac MRI was requested. So these are the cardiac MRI images, and as expected, very similar to our echo findings, it also showed dilated LV, inferior wall akinesia, and rest of the segments were hypokinetic, severe LV systolic dysfunction. But what we were actually more interested in cardiac MRI was actually the LGE pattern. So typically, if we talk about cardiac sarcoidosis, the LGE pattern seen in cardiac sarcoidosis is patchy and involving multiple sites, and it is usually epicardial in location and mostly involves septum, LV free wall, and RV free wall. Now, in our finding, this was totally different from what we usually expect in cardiac sarcoidosis. So what we found that there was LGE pattern was there, but it was not patchy and it was not at multiple sites. It was confined only to the inferior wall, and it was not epicardial. It was subendocardial scar with about 50 to 75% transmurality and total scar burden of 13%. So this subendocardial scar with transmurality was actually suggestive of myocardial infarction and not sarcoidosis. So this was a bit odd, but in the meantime, patient also underwent FDG PET, which showed multiple large prominent lymph nodes scattered all over the body from top to bottom. And it also showed significant myocardial uptake. But again, similar to cardiac MRI, it was limited to only the inferior wall, and there was no abnormal metabolic activity identified anywhere in the myocardium. Now, again, similar to MRI, FDG uptake was also confined to the inferior wall, suggestive of intense active inflammation in that region, but implying that the scar which we had seen on MRI was not just a simple myocardial infarction. So we proceeded further. And because patient had multiple lymph nodes, so ultrasound-guided FNAC from one of the inguinal lymph node was done, which showed non-caseating granulomas with epithelioid cells, multinucleated giant cells. ZN staining was negative, and the gene expert test was negative. So on the basis of all these findings, we finally made a diagnosis of sarcoidosis with cardiac involvement. Now, what was bothering us that the subendocardial scar and the transmural infarct, which we saw on cardiac MRIs. So we thought that let's rule out coronary artery disease also in this patient. So we did coronary angiogram in this patient. And surprisingly, we found a double vessel disease in this patient and involving LCX and RCA. And here we can see that RCA is actually huge. It is super dominant. And we can see that the PDA is actually going all the way up to the LV apex. And there was in the distal RCA, there were multiple critical lesions. Now, although these lesions could be because of atherosclerosis itself, but because there was intense FDG uptake in the inferior wall, so it was more likely to be of inflammatory process and not just atherosclerosis. So we made the diagnosis of cardiac sarcoidosis with coronary vasculitis in this patient. Now, because this patient had active inflammation on FDG, so patient was started on immunosuppressive therapy in the form of steroids. Rifampicin was continued by the pulmonologist. Heart failure therapy was started. And because this RCA was huge, so PTCA with stenting to RCA was done along with DAPT and statins. So this patient presented again 3 months later. Initially, there was some improvement in the LV ejection fraction to 35 to 40%, but then patient did not do any regular follow-up with us. And about a year later, patient presented to us and we came to know that he was non-compliant to treatment. And this time he presented with sustained ventricular tachyarrhythmias and an ICD implantation was done. So now the patient is in our follow-up and is in regular follow-up, but unfortunately his EF has not improved. So So this was a case where patient presented with not just myocardial involvement, but also coronary involvement. So I would just very briefly discuss about this entity. So cardiac sarcoidosis, sarcoidosis is a multisystem disease, and the cardiac involvement can present with whole lot of clinical spectrum ranging from silent disease to sudden cardiac death. Clinically, even cardiac involvement can be seen in only 5% of the patients, although autopsy studies and MRI studies report that it is much more common than that. It is reported in about 25 to 30% of the patients. And once the heart is involved in a patient of sarcoidosis, it significantly increases the mortality in that patient. And in fact, it is one of the leading cause of death in sarcoidosis, accounting for 3/4 of the deaths in these patients. Now, coronary involvement in cardiac sarcoidosis is even rarer, and on Medline research, I could find less than 15 cases. And the most common mechanism for coronary involvement is actually coronary vasculitis, and which can lead to total obstruction of the coronary arteries because of the thrombus formation or because of the fibrosis. And then it can also lead to coronary aneurysm, coronary dissection, and very rarely one case has to be reported about the coronary cameral fistula. The other mechanism could be the coronary atherosclerosis acceleration. Now, sarcoidosis is also an inflammatory disease, and it is possible that if a patient has atherosclerotic disease prior to this, and then presence of coexistent sarcoidosis can actually accelerate that atherosclerotic process. And in our patient, possibly he had coexistent atherosclerosis, and which was worsened by inflammation. But because there was undisputed intense FDG uptake in the RCA territory, so we believe that in our patient, vasculitis was the predominant mechanism. So finally, to summarize, so our patient presented with cardiac sarcoidosis with active coronary vasculitis, which manifested in the form of severe LV systolic dysfunction, RWMA with myocardial scarring, and ventricular tachyarrhythmias. Thank you.
Thank you. Thank you. Any comment from the faculty or?
Yes, I have I want to know, do you think it is a separate entity, sarcoidosis, or as well as atherosclerotic disease?
See, we do believe that this patient might be having some atherosclerosis, pre-existing atherosclerosis, but because there was intense FDG uptake in this RCA territory only, so we believe that it is not just atherosclerosis which has caused obstruction in the RCA, it is the vasculitis plus atherosclerosis which has caused the obstruction. Because if I say that this is only atherosclerosis, then I would not expect FDG uptake in the RCA territory.
So you think the vasculitis is due to sarcoidosis?
Yes.
Okay.
Thank you. Have you got your next presenter here?
Yes.
Yes, sir. All of them have joined.
Yeah. So the next, I think, yeah, next presenter you can call, please. Nurul Islam, or who is there?
Manoharul Islam, sir.
Yeah. Yeah.
Yes, Manor.
Yes.
Put your slides on.
Good evening, sir.
Can you make it larger? Yeah.
Click here. You're on the right.
And the title is The Unbreakable.
We can see your slides. You can continue, please.
Year-old lady who is the mother of only son of 6 years, presented with fever, cough, and just shortness of breath. And she was diagnosed with a case of exudative pleural effusion. Anti-TB drugs were offered, and ultimately there was no response. Clinical workup revealed mild anemia, raised temperature, and raised JVP. There was mid-diastolic murmuril mitonuria, and the ESR was quite raised to 90 millimeter mercury. Blood and urine culture came negative, and pleural fluid aspiration revealed just exudative pleural fluid. When echocardiography was done, these are the echocardiographic images of the lady. We are seeing multiple mass lesions within the left atrium, left ventricle, and also the right ventricle. Some are in close proximity with the valve leaflets. So this was a case involving multiple chambers of the heart. Short axis view on the left side, and on the right side modified 2-chamber view. we are seeing the lesions, and the subcostal view just makes it sure that there was no continuity of the masses with the inferior vena cava lumen. Just urgent surgery was done, and the excision biopsy revealed cardiac myxoma. So this was a case of multi-chamber cardiac myxoma. Considering these and from the background knowledge, we just screened the first degree relative of the lady, including brothers, sisters, and the only son. To our surprise, the son, who was absolutely asymptomatic at that time, just showed a large mass in the right atrium. And again, the subcostal view ensures that there was no continuity with the lumen of the IVC and the mass. Again, surgery was done, and when histology report was available, again, cardiac myxoma was found. So cardiac myxoma involved mother and the son. We had just revised look to the facies of the mother, and we found that there was multiple hyperpigmented macules over the cheeks of the mother. So an apparent presumptive infection turned to be a syndrome, as is characterized by the presence of multiple macules and also the histologically proven cardiac myxoma, and just first degree relatives are being affected. So this was a case of Carney complex. The case was reported in the Case Journal of the American Society of Echocardiography in 2020, and this would be the end of the story. Just as few information regarding the Carney complex. This is an autosomal dominant disease characterized by myxomas in multiple sites of the body, and also the tendency to have endocrine organs, and also the lentiginosis affecting the skin. And this is diagnosed by application of a diagnostic criteria having 11 major and 2 supplemental criteria. And when we just applied the criteria to our cases, this confirmed the diagnosis of Carney complex. The mother and the son were kept on continuous follow-up. And you are seeing just the post-op echo 1 week after the operation of the mother. And we are seeing that there was no residual tumor. And on the right side, this is the echocardiography 4 years after the operation in the November last year. And here we are seeing that there is some just moderate mitral stenosis and moderate mitral regurgitation, but there is no obvious evidence of recurrence or new growth. Like the mother, the son was also kept on continuous follow-up, and you are seeing the echo 2 hours after the operation of the son. And if we look carefully and just into the left ventricle as well as into the right ventricle, there are some suspicious appearance of growth occupying the walls. And you are seeing just the zoomed up view of the lateral wall of the left ventricle. And this, there is a mass in the child. And this is the echo just done November last year. And by this time, at the 4 years after the operation, the mass within the left ventricle has grown to a larger one. And also this is to some extent friable. And the right ventricular mass was just like the previous one. So what would be the further treatment strategy of the son? Should we operate him again, or should there be watchful observation? We took the just opinion of the cardiac surgeon, and just the surgeon opined for that there could be some watchful observation and close follow-up of the patient. Just we searched the literature for further information regarding this unusual complex. And this is a report recently published from the Mayo Clinic of America, and they reported 38 cases of Carney complex over 50 years. And out of the 38 cases, 24 had cardiac myxoma. So for the diagnosis of Carney complex, presence of cardiac myxoma is not a must. And when just they reported their experience, they shared their experience, they actually dealt with the recurrences with conventional surgery, except for a few cases that were just treated with ablation and angiovac. And 1 year survival was 100%, 5 years and 10 years survival was 66 and just 17% nearly. So my take-home message is cardiac myxoma can rarely present with prolonged fever and pleural effusion, leading to chances of misdiagnosis. Multi-chamber myxoma should raise the suspicion of Carney complex. Echocardiography plays a pivotal role for diagnosis, treatment planning, and follow-up. First-degree relatives should be always screened. Post-surgery recurrence of cardiac myxoma is common, demanding lifelong follow-up. Thank you all with these images.
A great case, a great case. Good.
Thank you, sir.
So, thank you. So now we call upon Dr. Anirudh. All of them have been to Bangladesh or so. He's a consultant non-invasive cardiologist at Surakja Diagnostics in Kolkata. And he has a very simple thing, or say, think simple, diagnosis will glare at you. I don't know. I wish all diagnosis should glare at us.
Thank you, sir.
Please.
I think my slides are visible. My slides are visible.
Please, there's some cross-talking going on.
Yeah. Just a minute.
Dr. Anirudh, you will have to present from one device, actually. I think both devices are on. Dr. Anirudh, we can't hear you. Please unmute yourself.
Unmute yourself, please.
Yeah, I think he exited from one ID and Dr. Anirudh, you'll have to unmute yourself. We can't hear you.
Hello.
Yeah, now you're audible.
Yeah, you are audible?
Now
Yeah. Now you can come to the bigger one also. Yeah, you can start.
Yeah. Now it is seen. My slides are seen quite clearly.
Yeah.
Actually, it's a tale of two countries. My case is a 14-year-old boy from Bangladesh presented with reduced appetite, presented with cough and cold, dyspnea of class 2 to 3, pulse 100 per minute, blood pressure 90 by 60 millimeter mercury, edema fit, abdominal distension, JBP raised, and of course the ECG reported normal. And one echo report they showed from Bangladesh is a mild LV systolic dysfunction with a mild pH. And this case was diagnosed the case of cirrhosis of liver with ascites by USG abdomen at Bangladesh and referred to a hepatologist of India for further treatment. Here in Kolkata, examined by a hepatologist and advised repeat USG abdomen with relevant liver function test. And they reported features suggestive of Barchieri syndrome. Then again, they sought a cardiological consultation and repeat echocardiography advised by the treating cardiologist. Then case comes to me. And here is the ECG of this patient. I don't think there is nothing abnormal for this 14-year-old boy. And is the first clip of the echo where you can see maybe a little LV dysfunction and maybe a little more thickening in the infraposterolateral area, nothing else. Next thing, the other clips. Color Doppler in this parasternal long axis view is nothing abnormal. Then there is, in M mode, there is some paradoxical motion of the ventricular septum. I could not get the proper fourth chamber view in this patient because somehow a proper fourth chamber view is not possible to get. So it's an off-axis view. What I could say is a biatrial enlargement, a little bit of LV dysfunction, even RV dysfunction could be seen. There are other views I can show you, but nothing all are classical views I could not get. So these are the views, that is modified 5-chamber, you can call it. but again showing almost the same features, some jerky motion in the septum and all these things. This is the short axis view. You can see, appreciate there is some LV dysfunction, RV is dilated, and some dysfunction is also, with some thickening in the inferior posterior border area, with some thickening and calcification might be. Mitral inflow Doppler, almost normal for the 14-year-old boy. E prime in the lateral is going up to 15 millimeter, and in the lateral is less. Tricuspid valve, maybe a little more grade 1 or 2 tricuspid regurgitation, RA is enlarged. And pulmonary artery pressure is a mild elevation of pulmonary artery pressure near about 40 to 45. TAPSE is only 12 millimeter. S prime is 7 millimeter. So there is definitely RV dysfunction. And this is the hepatic vein Doppler showing the reversal of flow. And that I showed in the how the reversal looked like. Global longitudinal strain is definitely reduced near about 12, average is 12. And of course, the inferior posterior areas are much more involved than the septal and anterior wall. Minus 12.1. So I diagnosed this case by echocardiography case of constrictive pericarditis. And this patient was sent to for CT. And here is the CT. And in the CT, you can say clearly, very good. The heart is totally encasing by the thick pericardium, including the total calcification around all over the heart. You can see. That's why I put the whole movie. You can see very, very carefully that the heart is totally encased by the thickened pericardium from top to bottom with the thick calcifications. Another view. Very good. You can see this.
Are you not going to the new clinic? Which is
Golf course? हाँ मैं जाता हूँ मैं Wednesday को जाता हूँ morning में.
Another view.
Next वहाँ दिखा दूँ आपको.
दिखा सकते हैं. बिल्कुल दिखा सकते हैं.
ये आप where would you recommend this to be done, sir?
Who is talking, bhai?
There you can see the huge calcification around the whole of the pericardium from base to the apex.
Nothing to worry.
Everywhere.
Nothing to worry. लेकिन मैं ये चाहूँगा कि आप अब इसको
in there is a PDT construction, you saw the whole of the heart is encased by the thickened pericardium with specks of calcification everywhere. So the CT recorded is the circumferential pericardial thickening with calcification associated with the mild pericardial effusion, severe tear with dilated IVC, biatrial dilatation, features are keeping with the constrictive pericarditis, mild right pleural effusion with fissural extension with no significant pleural thickening, diffuse subpleural parenchymal and linear atelectatic bands in the underlying right parenchyma, multiple centrilobular ground glass nodule distributed in the periphery of the left, likely due to underlying active infective etiology, few enlarged mediastinal lymph nodes, surface irregularity of the liver with caudate and the left lobe hypertrophy, mild splenomegaly and moderate ascites. Obviously, then MRI was done again. And MRI is also almost showing the same thing, thick calcification around everywhere. And you can see in the T1, T2, both images, thick calcification, you can see thick calcification everywhere, you can see. And here is again, the look is the thick calcification back to bottom. And all these features you can see. So cardiac MRI, they reported non-dilated LV with a LVEF of 50%, non-dilated RV with RVEF of 45%, IVC and hepatic veins are dilated, biatrial dilatation with moderate to severe tear, circumferential pericardial thickening and calcification with mild diffusion. But very contrasting feature is there no features of myocardial inflammation or infiltration or infection. But still the GLS is reduced. I thought in the echocardiography, some myopericardial involvement is there, particularly in the inferior posterior part, but no dyskinesia or outpouching. Mild right pleural effusion with fissural extension and underlying right lung infiltrate. CMR appearance are those of constrictive pericarditis. But here is the click. Only in these two countries, only one investigation we missed. Both the countries. What is that? And that's why here is my title, is the diagnosis with clarity. Even if nobody has done the chest X-ray in this patient. And the chest X-ray you see, there's a very good linear calcification in the whole of the body, including it goes to up to the diaphragmatic part. So that give you a simple diagnosis. Probably you're dealing with the constrictive pericarditis in this particular type of case, without doing even the Budd-Chiari, cirrhosis of liver, CT, pericardial. So that's why my diagnosis is think simple, diagnosis with clarity. Then this patient was subjected to the operation. And this patient was given the AT drug for 6 months, and this patient was subjected to the operation. And the post-operative constrictive, I'll show you, this is the operative finding in the OT. Entire myocardium encased in the thick fibrotic calcified pericardium, and pre-operative CBP was 30 centimeters of water. And the details of the procedure are the midline sternotomy done, thymus dissected and ligated, excision of the adherent pericardium commenced from LV apex by fine dissection and cauterization, then carried out to the base of the heart, freeing the heart entirely from the adherent pericardium. Similar pericardium freed and excised over the ascending aorta, MP and the great vessels. Dissection resumed on the right side, freeing the SBC, RE appendage, RA, RV and the IBC. At the end of the procedure, brisk myocardial contraction achieved with improvement of blood pressure and follow-up CVP to 10 centimeters of water. And perfect hemostasis achieved. Sternum closed, keeping mediasternal both pleural drain, skin and subcutaneous tissue closed in layer, patient shifted to ICU, and the end of procedure, swab and instrument was corrected. And this is the post-operative chest X-ray, you can see. But still you can see some linear calcification in the diaphragmatic part of the pericardium. And the echo I have done in the post-operatively, and you can see this absolutely superior vena cava flow is excellent. IVC is contracting beautifully with the normal size. Hepatic vein Doppler is also normal. And you can see the normal hepatic vein Doppler, how it looks like. And this now you can see the entire heart is contracting beautifully. There is nothing, no LV dysfunction, no RV dysfunction. Color Doppler shows the same thing, nothing abnormality. You can see the beautiful contractility of the left ventricle, and you cannot see any thickening anywhere in the heart. And now we can, in this case, now we were able to see the proper fourth chamber view after the operation. And you can see they still probably left atrium a little bit enlargement is there, but it is resoluting in compared to the previous one. RA is also normal, and color Doppler is okay. This is there. And now you see the tissue Doppler in the mitral annulus is near about 10, and in the lateral again gone to the 15. That's just gone back to the normal phenomenon. And TR is also less, maybe a little bit, grade 1, and peer pressure is almost normal, 30-35. And this is the RV, and we can see, and this is the two-chamber view. And again, you do the average GLS, you can see this is absolutely normal, 21.4%. And no damage, no residual damage is taken. So this is my case. Thank you, everybody.
Thank you. Just one thing, although the diagnosis is quite evident, but did you get these features of an accelerated ventricular dependence on parasternal long axis view? Because
yes,
two you have to demonstrate. This thing and dissociation between intracardiac and intrarespiratory pressures also. So did the mitral valve show the variations?
Yeah. But that was there. I could not get the slides. I could not put able to put the slide. There's what there. More than 50% variation was there.
Okay. So, because I think very correct, because patients have been sent for liver transplantation, they have been turned out to be constrictive pericarditis. So you have to think this unexplained cardiac failure, diastolic failure, that is, one has to think about it. And as you rightly said, that was the reason that the diagnosis was missed, and now you see it was really glaring for you. Good case.
Chest X-ray is the investigation.
Yeah.
So thank you, Dr. Unroofed. How are you?
Fine, sir. How are you?
I am
So-
also fine.
So can you call?
if we are facing such a case, at last we have to consider chest X-ray as well as echocardiography.
Could be. Chest X-ray is still a good modality of investigation. We should not. We should not.
Patient suspecting cirrhosis, in that case, we have to consider these two investigation at least. Okay.
Also, sir. Thank you.
So you can call your next patient, next presenter, Professor Rahman.
Next presenter from Dr. Okay, or no?
Lord Chaudhary.
Yeah, Sam Chaudhary. Yeah.
Yeah.
Naharuma Chaudhary.
Yeah.
Yeah. Dr. Naharuma.
Can you unmute yourself, Chaudhary? Can unmute yourself, please?
Yes.
Sir, am I audible, sir?
Yeah.
Yeah, your slides are there and you're audible.
It's nice to see you all again, and thank you for giving me this chance. And I'm Dr. Naharuma Haidar Chaudhary, Associate Professor, Pediatric Cardiology Department of National Heart Foundation from Bangladesh. We know sometimes the difficult and rare cases are to diagnose is very difficult and tough one. So the physicians or doctors have to be like a detective. So I keep my topic, the title is Sherlock Holmes of Medicine, Cracking Unsolved Cases. And I'm going to share two cases, which is very rare, and it is less than 0.5% among the all congenital heart disease. It is a 6-year-old having distress and chest pain with failure to thrive. And patient have cardiomegaly with pansystolic murmur at the apex. And chest X-ray showed the cardiomegaly with increased pulmonary blood flow. And the ECG shows a long Q wave in lateral lead 1 and AVL. Along with there is ST depression in the all lateral leads. This is the echocardiographic finding. In short axis, we find the LV is dilated along the severe LV systolic dysfunction, and biochemically also we raised pro-BNP level. And this is the 4-chamber views where along with the dilated left-sided chamber, we get significant mitral regurgitation. And these are the other views, and we get some clues. We thought that why there is severe LV dysfunction. It might be cardiomyopathy, or it might be any ischemia, or it might be coarctation of aorta, or might be other shunt lesion which causes the LV dysfunction. But these two views give a good idea that there is marked echogenicity involving the mitral valve, chordae, and the papillary muscle. And this is the grade view, short axis view, grade vessel level, and we all practice, and I get my clue and my diagnosing point that the coronary artery is abnormally origin from the pulmonary artery. Before going through more elaborate discussion on this view, I want to show how a normal coronary looks. Aortic cusp has 3 sinus, right, left, and non-coronary, and this left main arises from the left sinus and going anteriorly and posteriorly the LCX, and right sinus goes like this way. And what is the color of this left anterior descending and the left circumflex? As because it is arising from the aorta, there is antegrade flow, so it is going towards the pointer, so it is yellow color, and it is going L6 going in the posterior atrioventricular groove, so it is blue color. And with this color, we can identify the normal coronary, and along with 2D, we give the idea where it arises. But what happened in my case, we see that the 2D, the coronary arising from the posterior sinus of the pulmonary artery, which lies anteriorly. After the left main, it is dividing left anterior and left circumflex. Here the color is reverse than the normal. Why this reverse flow? As because the pulmonary is low pressure grade vessel, so it is not maintaining the antegrade flow, and it is retrogradely filled by the collateral from the right coronary artery, which is arising from the right aortic sinus. So it is the flow reversed, and there is coronary stealing, and we are getting reverse flow, which is nicely demonstrated in this view. So I got that there is abnormal coronary origin, and along with there is severe LV systolic dysfunction with dilated left-sided chamber with moderately severe MR. And we did the CT angiogram. It also reveals that aorta giving rise to right coronary artery and main pulmonary artery giving the left coronary artery, and the right coronary artery is dilated. And we did the operation of this patient. We resected the pulmonary artery, and this is the left anterior descending. I have make a simple version of picture, and we take this, we make a patch or tunnel with the pericardial patch, and this is the Takeuchi surgery, where the left coronary and with the tunnel, it is joined with the left anterior sinus, so that from the left aortic sinus, left coronary artery get blood, not from the PA, and we then transected part of, we make again incision. And this is post-operative echo. LV function is increased, and my mitral regurgitation also improved, and patient functionally improved, and we discharged the patient after 15 days with heart failure. This patient again developed a pulmonary stenosis after 4 years, and redo surgery was done in this patient. And these are the surgical complication that may arise in a case of our ALCAPA repair. My case 2, who came at only 2.5 months, he is also symptomatic, and we get also pansystolic murmur with features of congestive heart failure. And there is also X-ray shows cardiomegaly with increased pulmonary blood flow, and ECG like my first patient, and ECG is sensitive for ALCAPA in 60 to 80% cases. And this is the two view where we get here in this patient, the LV function is preserved, and along with preserved LV with dilatation is there, but patient developed significant mitral regurgitation. And this is a very nice view where we can delineate from the anteriorly placed pulmonary artery, left main arises in 2D, we can delineate, and a very nice picture where we can see that reverse flow is getting by the collaterals, which is arisen from the RCA. This RCA is yellow color, and after when the collateral is supplying, there is retrograde flow, and the LAD is blue color, and LCX is yellow color because they are getting reverse flow from the collateral circle. So only this 2D and the reverse color flow, we can diagnose this rare congenital abnormality. And if we see the RCA, it is dilated because the RCA is making the collateral, so RCA is dilated. And sometimes it is not evident, but in the most cases, when collateral develops, we get this dilatation. So there is also a final impression, anomalous left coronary artery from the pulmonary artery with good LV systolic function. Sorry, there is a dysfunction written with a dilated LA and LV, and there is moderate MR. So there is also CT scan done, and it showed that the left coronary artery arising from the pulmonary artery, and the right coronary, which LCX is also arising from the pulmonary artery. And this is the post-operative echo where the coronary is nicely reimplantation done, in this case, in the left sinus. So here we found that the LV function is preserved, and the recovery rate is very, we discharge this patient within 7 days with stable condition, and the patient remain in regular follow-up. So what is ALCAPA? We know that normally the left and right coronary artery arises from the aorta, and it is supplying with a diastolic pressure of 70. But when the anomalous coronary arises from the PA pressure is less, around 20/10 millimeter of mercury. So there is no antegrade fluid. So what happened in fetal period? In fetal period, the pulmonary get oxygenated blood supply, and the pulmonary pressure remain high as because in intrauterine period, the PVR is high, so antegrade flow is established by this pulmonary artery. But after birth, after the 1 month, the patient, the PA pressure, pulmonary vascular resistance come down, and the antegrade flow remain for few months after the PA pressure, and the PA gives the deoxygenated blood supply, and myocardium get infarcted and ischemic region. But while the time goes beyond, the collateral may develop, and it comes from the RCA, and when the collateral comes down, it goes and retrogradely fill the pulmonary artery, and there is coronary stealing, and there also contribute the more infarction, and the time when goes, there is scarring, and then patient may develop arrhythmia, or patient may develop heart failure, or patient may develop sudden cardiac failure. So with these features, with this pathology, we can identify the cardiac complication what may arise in ALCAPA. So my take-home message, patient may be symptomatic mostly, but in early cases may be asymptomatic. And only chest X-ray can reveal cardiomegaly with left-sided chamber enlargement with increased pulmonary blood flow with plethora. And ECG is a very good diagnostic tool where it is evident deep Q in lateral lead along with inverted T wave in this lateral lead. And echocardiography give a very good and nice demonstration of anomalous origin of left coronary artery, and we might found the LV functions normal or dysfunction, and we get the MR or echogenic papillary muscle or mitral as because the infarcted of LAD due to LAD supply. And surgery is simple ligation of ALCAPA or coronary artery bypass grafting or channel repair tracheostomy surgery that one of my patient done, and coronary reimplantation. So with the quotation of Sherlock Holmes, I want to conclude my session. You see, but you do not observe. To a great mind, nothing is little. And never trust to a general impressions, but concentrate yourself upon details. And thank you all.
Very good cases and very nicely demonstrated by diagrams, and very good color flow mapping you have shown. So it is the diagrammatic explanation, because we have seen so many cases have been described to us, but not in such a clear manner with the color and everything. Very good. Thank you.
Thank you. Thank you, sir.
Now we call Devika Chatterjee, who is the senior consultant and head of the non-invasive department in a very prominent institute in Kolkata. She will be presenting a case that baffled me. So if that case has baffled her, I think it will baffle everybody.
Dr. Chaudhary's name kept as Alive Heather Chaudhary, not I. It should be Alive Heather Chaudhary.
Sir, no, this is IV Heather Chaudhary.
Alive, yeah, as Rakesh
Alive
said.
Heather Chaudhary.
Good. So where is?
Can you see my slide, sir?
I can see you only, but not this slide.
Sir, you took away my words, you know.
Can't see my slide?
No.
You have to share it, Devika.
Oh my God.
Ma'am, you give double click on the share button on your slide, PowerPoint presentation. Give double click.
Can you see now?
No.
Not yet.
Oh my goodness.
We can see only one thing, either Devika or slides.
Sir, what to do?
Rakesh can guide you.
Can you see the share button, Devika?
Shared button I have shared, and then after that it opened. I don't know what's wrong. Should I go?
Yeah, unshare it and share it again, please.
Okay, quit. I'm quitting, huh?
Don't leave. Yeah, just unshare your slides if you've already shared them.
Ma'am, just check your presentation is selected or not after share button.
Now I can't see the share button. Oh my God.
That is why I said you must practice.
Sir, I'm calling my husband for a minute. to help
Why?
me.
Devika, what is?
Sir, what I'll do is I'll go and start my presentation.
Yes, sir. You please start and I'll join later.
Good evening, everybody. Thank you very much for giving me an opportunity to talk on this platform. I hope all of you can hear me. Something noise, what I'm going to present this time over here. And the caption of my presentation is this, ye dil mange more. That's what we want more. My heart wants more. Let's look at the case number 1. 1.7 meter square body surface area, hypertensive subject on irregular medicine. BP appears to be uncontrolled. Presented for routine echo examination on demand by a physician. Blood pressure 200/110, right arm supine. Then nothing significant as far as clinical examination is concerned. Mild dyslipidemia, chest X-ray normal, ECG normal, and look at this echo now. Only one finding which will strike you over here is dilated LA as per body surface area. Normal is 22. We have 23.5 indexed LA size. Second is we went on to do a parasternal short axis view of papillary muscle to look at the hypertrophy. As per JS 2016 guidelines, we classified this patient into concentric LVH with RWT more than 0.49, LV mass more than 117. And the cutoff for this particular person is 115 and 0.42. So we classify this patient into left ventricular hypertrophy. LV systolic function absolutely good. Now you can look only the some amount of hypertrophy which you can see in these slides over here. Ejection fraction was great. We went on to do a diastolic function and look at his EA ratio, then TR jet velocity gradient, and based on 2009 guidelines, it's classified into grade 2 diastolic dysfunction because with inspiration, it was reversing to small e, tall a. So our diagnosis, dilated LA, LVH, concentric hypertrophy, normal LV systolic function, grade 2 diastolic dysfunction, mild MR, normal pulmonary artery pressure. My question is, majority of us, we stop over here. Are we done with the echocardiography or do we know more? And that's what I say the caption is, ye dil mange more. Well, complete evaluation of a systolic function in 2025, we talk of a global longitudinal stain. We went on to do a GLS and look at this GLS of this patient. If you look at carefully, the same patient we were saying that concentric LVH, now his GLS is minus 17.7 with apical sparing. One important issue. Second is we went to 2016 guidelines of echo function for diastology. Then we look at the E ratio, E prime septal, E prime lateral, LA volume index, and putting them on this table of just 2016, we classify this patient as grade 1 diastolic dysfunction with normal LA volume index. Now my findings are classically changed. We have a dilated LA, LVH or a concentric LVH with apical sparing suggestive of some deposition disease, maybe a amyloidosis by GLS. Normal LV systolic function or reduced LV systolic function because of a reduced GLS. Grade 2 has become grade 1 diastolic dysfunction, normal pulmonary artery pressure and mild MR remains the same. Now look at this classification of JAC 2021. Stage B heart failure is structural heart disease with abnormal cardiac function. We have a structural heart disease, LA is dilated. We have abnormal cardiac function, GLS is low. And on top of that, look at the JS 2014 presentation on apical sparing. We have this patient possibly suggestive of amyloidosis. Now, what is the final outcome? Concentric LVH with a pattern suggestive of amyloidosis, normal LV systolic function or reduced LV systolic function of GLS. At least grade 1 diastolic dysfunction with normal LA volume index and stage B heart failure. Yes, truly, it's a stage B heart failure. And if you remember 2019 volumes of a JAC, which specially published on aortic stenosis, with LVH, they said almost 19% of the patient having LVH has got amyloidosis. Now, other investigations and treatment, what do we have in our armamentarium? Tight control of blood pressure, subject them for amyloidosis, treat them as stage B heart failure. If not, they'll go to stage C. And hypertrophy remains such, then look at this particular paper published in JS 2011. More the hypertrophy, more the cumulative incidence of mortality and morbidity. And more the hypertrophy, fewer chances of survival over a period of time. And that's what was a take-home message. What else modality can give you better than this? It gives you a cause, It gives you a treatment option and prognosticate a patient of just a simple looking innocuous patient of left ventricular hypertrophy and presenting to your labs. So it's not an echo, it's a perfect detailed echo talking of a detail about echocardiography. Moving on to case 2, elderly patient, again hypertensive, referred for. And for the first time, physician heard a systolic and diastolic murmur. Amazing, nobody used a step in this particular presentation. BP 180/80, both systolic and diastolic murmurs was present. Occasional cramps, nothing significant as far as investigation is concerned. Most important thing is, look at the aortic knuckle. As Dr. Anirudh was talking of XHS, we always look at an XHS, BP, and on top of that, ask a patient why you have come to our lab to get your echo done. Next, nothing significant in ECG. Echo, there's something which is apparently seen normal, good contraction, very good short axis view, and not significant mitral regurgitation. But when we put up all these things together, look what is striking in this patient. The striking feature in this patient is presence of calcification, which is virtually present across all valves. And remember, we looked at a knuckle, aortic knuckle, which was calcified in XHS. We look at a diastolic function. Look, the E wave is increased. So the person, a physician who heard the murmur was true, that mitral diastolic murmur was present. We look at E prime septal, E prime lateral LV volume index, and putting them all together, we classify this patient as a normal diastolic function with normal LV systolic function. Why diastolic and systolic murmur? That was the reason, because we have an atherosclerotic aortic valve in the mitral valve. Are we going to talk about all this, or should we go further? Obviously, the talk of this patient presentation is Dil Mange More. So we went on to this, looks at these valves and look at its diastolic functions. We went on further and looking at this, there's significant aortic and atherosclerotic calcification, increased flow velocity. This paper published in JACC Imaging 2015. Very interesting paper. We always look at the coronary calcium scoring. Look, it says papillary muscle calcification absent versus present. Mitral renal calcification absent, mild, moderate, or severe. Aortic sclerosis, ascending aortic calcification. We all can prognosticate these patients based on this calcium score of echocardiography. And if the calcium score is positive, look at the presence of poor survival, poor outcome. If these people are subject to treadmill test over a period of time, 50% of these people come out to be positive. It means to say that they are at a very high risk of a coronary artery disease if you happen to see a coronary calcium. And look, one important thing which was there, aortic knuckle. We just passed on this aortic knuckle, as Dr. Anirudh said, like we just passed on that calcified pericardium. And ECS demonstrated significant prognostic value in predicting hard cardiac events in multi-center population of patients who required non-invasive evaluations, and values independent of clinical assessment and wall motion during stress echocardiography. Fortunately, one medicine is available, vitamin K2 MK7, which is found to be a drug useful for reversing these kind of a calcification. So again, the take-home message is, this is possible only by echo, diagnosis, prognosis, and possible treatment. Last quick case, which tells you about our Vande Bharat Express, something like that. 62-year-old male, hypertension, who has a history of diabetes, hypertension, on regular medicines. History of smoking, alcohol is present, blood pressure is high, and the features of bilateral clefts and rhonchi and tender palpable river was present. Hemoglobin 14, borderline elevated, serum creatinine, SGPT was normal, urine albumin is present. Well, anybody can say what is the cause of this urine albumin. If you look at the paper published in 2012 and subsequently published in 2024, this is an unappreciated risk factor for cardiovascular disease, simple albuminuria. And if you look at this paper published in 2011, if you have a diastolic function abnormality, possibly your urine albumin is positive. XHS, partially inflated lungs, bony cage is normal, ECG shows evidence of LVH, and now look at this echo again. Beautiful looking LV function. You cannot have a better imaging than this. And then mild mitral regurgitation. We look at a diastolic function, EA ratio, E prime septal, E prime lateral, LV volume, and TR jet velocity. Most important factor, look at the LV volume, 38 ml, when the normal is 34 ml per meter body surface area. Put them together in this particular chart of GS 2016, patient classified to grade 2 diastolic dysfunction with raised LA volume index. Findings: normal LV systolic function, grade 2 diastolic dysfunction, raised LA volume. Anything else? No. We are not going to leave them like that. We went on to do something more. And what do we need more is, we went on to look at the LA stain of this patient. Look at the LA stain of this patient. Reservoir stain is only 29, conduit is 18, contraction is 11 with a large volume of 65 ml. And when you put them together in a place which is normal, it is definitely different, definitely low, and itself is suggestive of a higher degree of diastolic function. Normal GLS and normal RV-GLS, which is present in this patient. So we had left with normal LV-GLS, normal RV-GLS, abnormal LA stain. So further we say, is it okay with us? No, it's not okay. This patient is not normal, because look at this important finding of increased LA volume index and reduced reservoir stain. Look at this paper of Jack 2013 to determine the prognostic importance of left atrial dilatation in patient with type 2 diabetes with no history of cardiovascular disease. It says that increased LA volume index is independent incremental predictor of cardiovascular morbidity and mortality in type 2 diabetes with no history of a cardiovascular disease. And most important thing is, look at this slide of diabetic cardiomyopathy. Enlarged LA, impaired myocardial relaxation, elevated LV filling pressure, impaired GLS. We had both, like elevated LV filling pressure, which was present in this particular patient, who was absolutely normal. So again, classifying to grade 2 diastolic dysfunction, the raised LV pressures, volumes, and stage B heart failures, asymptomatic and going to be symptomatic in due time. This is one slide from Jack 2019. Look, this is the first one to get disturbed, and LA volumes comes later on. So in case, like, you happen to look at this population, this is one thing which is making a lot of difference. And one paper just published about a few days back, talking of looking at LA stain even in normal subject, and they did a follow-up. If your LA stain is abnormal, you have to have a significant chances of having atrial fibrillation in due course of time. I'm not going to talk of the management issues. All of us knows about this management issues. I only say this word. My final take-home message is, echo finding is important to diagnose raised LA volume index and reduce LA stain, suggestive of heart failure and episodic ejection fraction. They independent are the prognostic factor for cumulative mortality and morbidity. And if you look at 2025 paper, they says that if you have this raised LA volume index, reduce LA stain, the chances of having atrial fibrillation is very high. Thank you very much for your patience. Look, echo is not what we do. This is not the gorgeous picture of echocardiography, which we see every day. To look at the complete picture of echocardiography. Wait for 1 second, you will see a complete echo picture in due course of a time. And that's what the complete echo picture of echocardiography when you look at an echo properly. Thank you very much for your patience here.
Say, excellent. I will add 2-3 points more what Rakesh has said on the take-home messages. All of you must spend at least 1 to 1.5 hours daily in reading. If he would not have read, he would not have been able to diagnose. All of you should become members of American Society of Echo and American College of Cardiology for your updated journals. And what he has proceeded, what we call it, is a why syndrome. Now, he has found one abnormal finding. He wants to say why. Now, if you overlook those findings, that means it's gone. That means the why syndrome is very important in every aspect also. So I think they were fantastic teaching cases, and I hope they get some more cases like this. And I'm sure you'll present them when you go to Dhaka, if possible.
Sir, next time I'll present just LA stain, sir.
Sir, I want to comment. Sir, I'm really impressed about Dr. Rakesh Gupta's case. Detailed echo, all advanced modalities, and LA stain. Yes, it's very much time consuming. In a high volume center, we cannot practice all. I want to do, because doing LA stain, we can identify the case at a stage at risk of heart failure. So all advanced modality we should practice.
We are doing almost 25 to 30 cases every day now. Every patient gets out with a complete report. Believe my words, we are dead tired by the night.
Yes, you must be tired because
And if you get a complicated case, you don't
then you're gone.
provide more time.
Yes.
So I think Professor Rahman can call again to present her next case. Great case. That is why you are running a job teaching institute. Good.
Sir, this is your blessing, sir. Nothing I've done. Is all your guidance. Everything has made this.
No.
Your name is perfect, sir. And this is Y syndrome is your syndrome, sir. It's not mine. It's Dr. Parashar's Y syndrome, sir. Even the focused RVRA view is yours view.
No,
the
but
American
still,
Society of Echo hijacked it.
But you went by a Y syndrome. The why this is a lot, and that give you.
That is, next time I'll say Dr. Parashar's Y syndrome presentation.
No, okay.
No. Dr. Parashar is also combined syndrome of Bangladesh and India.
Yeah. So, Professor Rahman, can you call the next presenter, last presenter of yours?
Our presenter is complete. 3 presenters.
No. I think Tuhin is presenting one more case.
Okay. It's okay. Professor
And then we have...
Yes.
You will present another case?
Yes, I'm going to present another case.
Okay.
Okay, but I cannot share. Just a minute.
Is Debika ready?
Simi, yeah, I think I'm ready.
So you can come later on. Let her do first case.
Let Twin do. Twin, carry on.
Yeah.
Okay. Can you see my screen?
No, the Devika Chatterjee's name should go, then... Yeah, now let us see your screen, Yeah. A very young patient, now you can increase it, yeah.
Okay. So, a very young patient presented with non-ST elevation myocardial infarction. So, a 24-year male presented with chest pain, sweating, and dyspnea. He had history of intermittent chest pain for last 6 months. Risk factor smoking, dyslipidemia, positive family history of ischemic heart disease, and he was obese, and his cardiac biomarkers was raised and diagnosed as a case of non-ST elevation myocardial infarction. So ECG showed that there was T inversion in late 3 AVF and V1 to V6, indicating there is anterior inferior ischemia. Routine 2D echo before coronary angiogram revealed there was no regional wall motion abnormality and global ejection fraction was normal. Coronary angiogram revealed that there was normal right coronary artery. All the views showed that the right coronary artery was normal. Here we can see that also the left main and left LAD and L6 were normal. Again, the left main LAD and L6 is normal. So normal coronary arteries in a patient presented with a non-ST MI. Although atherosclerotic disease of the coronary arteries is the most common cause of luminal narrowing and coronary heart disease, there are multiple non-atherosclerotic causes of severe luminal narrowing. Approximately 4 to 7% of patients with acute myocardial infarction and nearly 4 times this percentage of patients younger than age 35 years have non-atherosclerotic coronary artery disease. Non-atherosclerotic causes of coronary artery disease includes congenital anomaly, embolus, dissection, spasm, trauma, arteritis, external compression, and substance abuse. Keeping all this in your mind, this time we reviewed the case and detailed and focused echocardiogram was done. Here we can see in the parasternal longus view, there is a small echogenic flower-like mass attached to non-coronary cusp. We proceed to transesophageal echocardiography, and we can see that there is a flower-like mass with multiple fronts and speckled echoluminescence at the edges attached to the non-coronary cusp. Short axis view showing that the mass was mobile mass attached to the non-coronary cusp. Here, the still image of the mobile mass showing that the small pedicle attached to the valve and a frond-like appearance with a speckled ecchymosis near the edge. This is a very typical characteristic, and as the mass was attached to the coronary cusp, non-coronary cusp of the aortic valve, and the patient was young and presented with a non-ST-MI, we diagnosed the case as cardiac papillary fibroelastoma. And we referred the patient to surgery, but unfortunately the patient did not go to surgery, and after repeated phone call, we lost the patient to follow-up. So with our provisional diagnosis, the cardiac papillary fibrostoma, and we think that because the patient was a young patient with a non-ST-MI, there was no coronary artery stenosis, and the mass was so typical of cardiac papillary fibrostoma, so we diagnosed the case as cardiac papillary fibrostoma. And now I want to share a brief overview about cardiac papillary fibrostoma in support of our diagnosis. Cardiac papillary fibrostoma is a rare primary benign avascular endocardial tumor typically attached to the cardiac valve. CPF are the third most common cardiac tumors after myxoma and lipomas and account for less than 10% of all primary cardiac tumors. The clinical presentation vary widely, ranging from primary asymptomatic to severe ischemia with embolic events. Right-sided tumors of the heart are commonly asymptomatic, or patients may present with pulmonary emboli. Left-sided tumors can result in life-threatening embolic phenomena. Here is the case showing the attachment of papillary fibrostoma to aortic valve. Non-coronary cusp, the papillary fibrostoma is attached. Regarding the epidemiology, it is a rare benign cardiac neoplasm. Because pulmonary fibrostoma are often asymptomatic, it is possible that the real incidence is underestimated. It predominates in adults and is particularly frequent between the 4th and 8th decades of life. Mean age of detection is approximately 60 years. Male sex predominates in most cases. Several mechanisms leading to the development of cardiac papillary fibrostoma have been proposed: organizing thrombi, congenital hematomas, iatrogenic formations, cytomegalovirus infection, rheumatic valve disease, true primary neoplasm. Natural history, there is a benign and develop over a period ranging from 6 months to 15 years. Postmortem studies have demonstrated dangerous complication because of the papillary configuration and soft, fragile nature. They are a potential cause of ostial coronary obstruction leading to myocardial ischemia and infarction. They may also act as a substrate for fibrin and platelet aggregation with subsequent peripheral or central embolization depending on the cardiac location. The majority of tumors are around maximum 10 millimeter, but tumors may as large as 70 millimeter. They has a characteristic flower-like appearance with multiple papillae fronds attached to the endocardium by short pedicle. Fronds are best visualized when immersed in water or saline. The gelatinous surface dissolves and multiple fronds become evident, giving the tumor the appearance of sea anemone. Here we can see the typical sea anemone picture after immersing the papillary fibrostoma in water. They are mainly had valvular attachment. Among the valvular attachment, aortic valve is the most common site, and some non-valvular attachment may also present. Location of fibrostoma attached to anterior mitral leaflet. So diagnosis, most cases of cardiac papillary fibrostoma have been diagnosed incidentally, transthoracic or transesophageal echo is the primary imaging modality. 3D echo have also been used for better delineation of cardiac papillary fibrostoma. Echo shows a small pedunculated or sessile valvular or endocardial mobile mass with a pedicle attached to the valve or endocardial surface and a frond-like appearance with a speckled ecchymosis near the edges. As you see that our case is that this typical picture and presented in a and was present in a young men who presented with non-ST-MI. So we diagnosed the case as cardiac papillary fibrostoma. Among the different imaging modalities, T is currently the preferred method because of its high resolution and optimal imaging capability, have a sensitivity and a specificity of 89% and 88% for the detection, can show the tumor's precise point of attachment, thus enables the surgeon to efficiently plan aortic valve repair, intraoperatively can guide the operation, and postoperatively help in evaluating valve competency. CT is inferior to TE in demonstrating the small moving structure. MRI is also disadvantaged due to its motion artifact. Cardiac catheterization prior to resection of papillary fibrostoma is subject to debate because of the friable nature of the lesion and because of the potential risk of embolization. On coronary angiography, the total occlusion or narrowing of distal coronary branches due to tumor emboli can be seen. The differential diagnosis include myxoma, thrombus, fibroma, LAMP excrescence, infective vegetation, thrombotic vegetation, rhabdomyoma, metastatic tumor, and mitral annular calcification. Since the surgical excision can prevent the devastating complication like cardiovascular and cerebrovascular complication, early diagnosis is essential, and algorithm for surgical management is that if any tumor is symptomatic, they should go a surgical excision. In case of asymptomatic tumor, if it is a left-sided and large and mobile mass, it should undergo surgical excision. On the other hand, if the tumor is right-sided and small and non-mobile, the serial echocardiography, serial follow-up echocardiography should be done. So prognosis, surgery is curative, and short and long-term prognosis after surgical removal is excellent. Recurrence after surgical resection has not been reported. Longest follow-up period is of 11 years has reported, and most patients underwent transthoracic echocardiography for follow-up evaluation. Tumor mobility is an independent predictor of occurrence of death or non-fatal embolization. So my take-home message, cardiac papillary fibroelastoma is a rare benign asymptomatic tumor, mostly involving aortic valve. Clinical course could be devastating, which includes systemic on pulmonary embolism and sudden death. Echo, particularly transesophageal echo, is the imaging modality to identify the location of the mass and the extent of anatomic and hemodynamic involvement. Confirmatory diagnosis of papillary fibrostoma is based on histopathology. Surgical resection by valve sparing shave is curative and safe, but short and long-term prognosis is excellent after surgical removal. Thank you for your kind attention.
Thank you. Thank you. There are some questions. We'll come to it later on. Now, can we come to Devika to present her last case?
Yes, sir. I'm sharing the screen.
What happened to your husband?
Yes, sir. He's sitting just next to me, sir.
What is he doing?
He is trying to help me.
But can somebody guide her how to? Yeah, now it is all right. She should be.
Okay, sir.
Bring your slides.
Because your voice is echoing.
That is good.
That is good. Can you see the slide, sir?
Yeah. It is increased size also. We can see now.
Okay,
Carry
sir.
on.
Thank you. Thank you. Thanks.
Carry on.
Devika?
Yes, can you hear me?
Devika? Yes, your voice is echoing, so probably you are on two devices.
Can somebody guide her?
Hello?
Yeah.
Somebody guide her. Hello? Is it clear now?
Better.
Is it clear now?
Devika, are you on two devices?
No, I'm not on two devices. I have I'm not on two devices. I have
Okay, sir. You start your present. You start your present.
Okay, so my case is a 50 years old female. 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 What is happening? Hello?
Yeah.
Hello? Yeah. Hello? The case was referred to our electrophysiologist from outside for the management. No, sir, it's not going in the right direction.
You can remove your mobile. Your mobile may disturb this one. Mobile may disturb this one. Mobile may disturb this one. Mobile may disturb this one.
My mobile is switched off now. My mobile is switched off now. Hello.
Cancer.
Hello.
Cancer.
There is too much of echo in your voice, and we cannot.
Yeah, I can also make out. Simbi.
You can log out and log in again.
Yeah,
I'll log out.
Log out and log in again. Otherwise, you don't.
Log out.
Log in again.
Leave waiting for.
Kunta, leave.
Just stop sharing.
Leave sharing.
Anirudh, can you hear me?
Yeah, I can hear you.
There is one question. That we echo findings and calcification on CXR. What additional information we are looking from CT?
Again, there is a lot of echoing. Why not? I don't know.
Can you see the question?
Yes, sir. I could not see hear the question properly.
You have already seen calcification on the X-ray chest.
Yes, sir.
So, what extra information you were looking for in CT or MRI?
No, sir. Calcification can be only in the one dimensions.
Yeah.
You cannot tell that the whole of the heart is encased. That what I showed in the 3D reconstruction of the CT, or even in the moving CT images. So that cannot be said. Only thing is that you can give you a glimpse that this person with such and such findings and the calcification in the linear calcification in the pericardium. So you can ascertain that this case.
And moreover, echo is a very poor technique to assess the calcification.
Agreed.
So the best way to see a calcification is by CT.
Exactly.
Patient who may not show any calcification on a transthoracic echo.
Yeah.
So that's why CT usually done.
CT is the ultimately the diagnosis to confirm.
CT is the ultimately the diagnosis to confirm.
If Rakesh is here, then the pulmonary vein Doppler to assess diastolic dysfunction, will it be useful to assess diastolic dysfunction? Say, normally what happens that we go by the usual parameters of a diastolic dysfunction by a mitral Doppler, tissue Doppler, LA volume index or so. But these are usually done in those cases in which there is slight discrepancy on the findings. So there we can do a pulmonary vein Doppler.
Sorry to interrupt, sir. Sorry to interrupt, sir. There is too much of echo. Sorry to interrupt. There is too much of echo. Sorry to interrupt.
Hello.
Yeah, Deepika. Yeah, Deepika.
Can you see my slide and can you hear me clearly? Can you see my slide and can you hear me clearly?
We
can you see my slide and can you hear me clearly?
There
Can
is a
you
lot of
see my slide and can you hear me clearly? Can you see my slide and
Is this echo is from everywhere?
all my devices are shut down. Other laptops, even my mobile is shut down.
Now your sound is better.
Okay, sir. I'll go ahead. My patient, a 50 years old female, referred to our electrophysiologist from outside for the management of basically RV cardiomyopathy with paroxysmal atrial fibrillation. She was carrying an echo report which showed dextrocardia, severe tear, enlarged atria, and dilated RV with systolic dysfunction. Our electrophysiologist advised for cardiac MR for confirmation of basically RV cardiomyopathy. The cardiac MR people ruled out the RV cardiomyopathy. There was no evidence of inflammation, infiltration, or any evidence of MI. RV was dilated with fair systolic function. RA was dilated with severe tear, moderate MR. LV was of normal size, but there was PH. Now, at this moment, the case was referred to me for echocardiography and giving the final confirmed diagnosis. So when she came to me, I found her with normal sinus rhythm. Heart sounds were normal. There was a soft systolic murmur at right sternal border. Our oxygen saturation was 96% at room air. ECG was in normal sinus rhythm. There was no atrial fibrillation. So I started doing echocardiography. It was a case of dextrocardia. As I said, you can see the LV, the heart is pointing towards the right side. Here's the liver. It was a situs solitus out of the left, IVC on the right. And as I went to the apical four-chamber view, I could see that her LA and RA and RV were dilated, so also the LA, but the RV systolic function was good with a TAPSE value of 17.5 millimeter. Parasternal long axis was a problem. It was a case of dextrocardia in an adult obese female. However, I could manage to get it where I could see a mild MR. I couldn't locate coronary sinus. This is our aortic valve, which is normal. And only LA was enlarged, good LV systolic function, and a mild MR I could see. Now here is our four-chamber view, which is showing torrential tricuspid valve regurgitation with TR vena contracta of 14 millimeter. And this was a low pressure tear with a tear gradient of 19.7 millimeter of mercury. Now, I looked at her pulmonary valve, which was quite normal, as you can see, confluent, but it was a bit dilated, and there was no stenosis. And now I started looking at the tricuspid valve, so also the interatrial septum. Now, I could see a coaptation failure of the tricuspid valve leaflets, but IAS was basically intact. Initially, it looked like intact, but I could see something here, something as you can see, here is the structure. Is it, the wall of the coronary sinus? I had a doubt. So I looked at it. Yes, to me, it looked like a dilated coronary sinus, which was draining into the RA. As you can see, as you know, dilated coronary sinus is usually associated with presence of left SVC, but I couldn't see. I tried to get it. RSVC I could see properly, but I had a very much doubt about the presence of LSVC. I was not very sure. Now, so to confirm the diagnosis, what it is, why the RARV is so much dilated, why there is so much of tear, we did a TE. Transesophageal echo showed this picture. As you can see, again, a torrential tear. This was our IAS. This is the LA, LV, LA and RA are enlarged, so also the RV, but LV was normal. It was a low pressure tear. Her aortic valve was absolutely normal. As you can see, there was no evidence of any other ASD. Now, then as I looked at LA, I could see this is the dilated coronary sinus. And now you know where we get the coronary sinus in transesophageal echo. Say as we go from mid-esophageal towards the transgastric, a junction will come of which we call gastroesophageal junction. That is the landmark of presence of coronary sinus. There, the coronary sinus. Can you see? I'm going down, so I reach the stomach. So before that, if you see here, this is the coronary sinus. Usually, it is seen as a thin lumen, and it is roofed. But in my case, very easily, I could open up the coronary sinus. As I went little down, I could see the coronary sinuses opening, and not only it's opening in the RA, it is also has a big opening in the LA, and with a flow from the coronary sinus to the LA. So it's basically to prove the diagnosis of unroofed coronary sinus. We did a saline contrast study. How nicely it is seen. You see, we did it from the left hand. As the bubbles are coming, you will see the bubbles will start coming. You see, yeah. Yes. So it's not coming. Anyway, so bubbles started coming from the LSVC, and it's going simultaneously to the RA and the LA. So that confirmed there, you see, it's coming, it started coming, and it will reach there simultaneously to the RA and the LA. So my diagnosis was unroofed coronary sinus. Coaptation failure of the tricuspid valve leaflets. To me, tricuspid valve leaflets structurally looked normal with torrential tear. I was very sure about the presence of right SVC, but I couldn't see the LSVC with good biventricular systolic function. Now, the surgeon opened the chest. They found dextrocardia, cytosolitis, normally related great arteries, but there was a anterior-posterior relation of the heart chambers. LALV were anterior, superior, and RARV were posterior. So they had a very tough time. So what they found partially unroofed coronary sinus, but they found presence of dual SVC. What they found, the LSVC was draining to RA, and RSVC was draining to coronary sinus, which was draining into the RA ultimately. So, and along with that, they also found an additional large posterior type of ASD, which I really couldn't see. So, coronary sinus defect is a very rare finding. It occurs less than 1% cases of ASD. It is basically not an ASD. It is a defect in the wall of the coronary sinus that separates the LA from the coronary sinus, leading to the interarterial shunt. And 75% cases are associated with persistent LSVC, which was present in this case. The surgeon found it. I couldn't locate it. So, so you see a case who came with a patient who came with the diagnosis of RV cardiomyopathy, turned out to be having a very, the rare congenital heart disease, and the surgeon did roofing of the coronary sinus with pericardial patch and the patch closure of the secondum ASD along with the tricuspid valve annuloplasty, and patient was discharged with no residual ASD flow, only mild tear. As you can see, this much of tear and this much of MR. So the take-home message of this case is that we should not have a tubular vision while doing echocardiography. With, if we get a finding, a little bit of suspicion, like in this case, it looked like a dilated coronary sinus. A simple contrast echo, bubble contrast echo, gave me the diagnosis, and we could give the patient a new life. Thank you.
Good. So there is one question for Professor Tuhin, that can supramitral ring be differential diagnosis for blood cyst?
No. Just a minute.
Can it?
suprametal ring or membrane, just a fixed structure, but it was a mobile cystic mass, and the mass was moving with the cardiac cycle. And in CT, we also see that it was a blood cyst, and it was confirmed by surgery and biopsy report. But the structure and the echo feature does not support the diagnosis of suprametal membrane.
Good.
Wasn't
So
that
if there are
isn't it? Tuhin?
any,
Yes,
yeah.
sir. Yes, madam.
It was in the aortic valve, isn't it? That
No. The first case was the blood cyst. It was attached to the mitral valve leaflet. And the second case, the papillary fibroelastoma was attached to the aortic valve.
Sorry.
So I think we had a sort of a very, very fruitful and very interesting cases. And they really went to that extent that we could not even guide what is the diagnosis. So is Professor Rahman here before his final comments, or we just say it was a great meeting and very great cases, and I hope we continue with such sort of a interesting webinars also. Thank you very much, all of you.
Thank you, sir.
Thank you, sir.
Especially
Thank you.
all of them, all cases we are excellent, I can say.
All cases we are excellent, I can say. All cases we are excellent, I can say.
What is happening? Silly.
Multiple echo.
Multiple echo from where?
Everywhere is echocardiography, so everywhere is echo.
Dr. Devika, how are you?
I'm fine, Professor Rahman. Nice to see you, though virtually. Nice to see you. See you all the friends from Bangladesh.
Yes.
Do you
think
We are seeing virtually, but we want to see in person.
Yes. Very happy to see you all.
We are also very happy, madam.
Yes, Madhwar.
Yeah, thank you.
Thank you, everyone. Nice to see you.
I think it is a unique